Ventilation is the process of moving air in and out or breathing. So, mechanical ventilator is a machine which helps in breathing. If is needed by those who cannot breathe spontaneously and cannot perform natural ventilation. Indications in which patient may need ventilator are coma, COPD, acute respiratory distress syndrome, heart failure, pneumonia, sepsis, trauma and post-operative complications. Types of ventilator are pressure-cycled ventilator, time-cycled ventilator and volume-cycled ventilator. Pressure-cycled ventilator are of two types: positive pressure and negative pressure ventilator. First is pressure-cycled ventilator. This type of ventilator pushes air into lungs until a specific airway pressure is reached. It is used for short period mostly in post-anesthesia care unit. In positive pressure ventilator, pressure is higher than atmospheric pressure and is applied to the intra-alveolar space during inspiration. It involves pushing air or oxygen into the lungs under pressure. When this pressure is released, the natural elasticity of the lungs allows the air to come out. This is the most commonly used type of ventilator. Example is dragger pulmotor. In negative pressure ventilator, pressure is lower than atmospheric pressure and is applied to the extrathoracic space during inspiration. In this, a vacuum or negative pressure is created around the chest. It causes chest expansion. Simply, it sucks air from lungs. It is currently not in use. Examples are turtle shell and tortoise shell. Second is time-cycled ventilator. This type of ventilator pushes air into lungs until preset time has elapsed. It is used for pediatric or neonatal client. As in this ventilator, preset inspiration time is 0.35 second. Third is volume-cycled ventilator. This type of ventilator pushes air into lungs until a preset volume is delivered. A constant volume is delivered regardless of the changing compliance of the lungs and chest wall or the airway resistance in the client or ventilator. As in this ventilator, setting preset tidal volume is 450 milliliters per breath. Before knowing modes of ventilator, let us know about ventilator controls and settings, which are tidal volume, respiratory rate, PSI, FiO2 friction of inspired oxygen, CPAP, continuous positive airway pressure, PAPE, peak airway inspiratory pressure, PEEP, positive and expiratory pressure, and pressure support. First is tidal volume. Tidal volume is the volume of air that the patient receives with each breath. In ventilator, we have to set tidal volume according to the weight of the patient, which is 5 to 10 milliliters per kg. As in this image, set tidal volume is 450 milliliters per minute. Second is respiratory rate. It is number of breaths delivered per minute. Normally it is between 10 to 20 breaths per minute. Next is PSI. It is the volume of air that is 1.5 to 2 times of the set tidal volume, delivered 6 to 10 times per hour. Used to prevent atelectasis. As, in this patient, one extra breath is given by ventilator and its air volume is more than normal tidal volume. It improves oxygenation and lung mechanics. Next, friction of inspired oxygen FiO2. It is the oxygen concentration delivered to the client determined by the client's condition and ABG levels. The level is between 21 to 100%. Next is CPAP, continuous positive airway pressure. It is the application of the positive airway pressure by ventilator through the entire respiratory cycle for spontaneous breathing. It keeps the alveoli open during inspiration and prevents alveolar collapse. Usually it is 5, 7.5 and 10 centimeters of water. Next is PAPE, positive airway inspiratory pressure. It is pressure needed by the ventilator to deliver a set tidal volume at a given compliance. Normal level is between 10 to 20 millimeters Hg. Next is PEEP, positive end expiratory pressure. It is the positive pressure exerted during the expiratory phase of the ventilation, which improves oxygenation by enhancing gas exchange and prevent atelectasis. Normal pressure is between 5 to 10 centimeters of water. The need of PEEP indicates a severe gas exchange disturbance. Higher level of PEEP more than 15 centimeters of water increase the chance of complications such as tension pneumothorax. More pressure, more severe tension pneumothorax. Simply, during expiration when the air comes out from alveoli, PEEP keeps the alveoli open and prevent collapse of atelectasis. Next are the modes of ventilator. There are mainly 4 modes. Non-invasive pressure ventilation or bilevel positive airway pressure, BiPAP, controlled mode, CM mode, assist control, AC mode, synchronized intermittent mandatory ventilation, SIMV mode. First is non-invasive positive pressure ventilation or BiPAP. A BiPAP system uses a nasal mask for pressure and volume controlled ventilation. Ventilatory support is given without using an invasive artificial airway like endotracheal tube or tracheostomy tube. In this, orofacial and nasal masks are used. An inspiratory positive airway pressure, IPAP, and an expiratory positive airway pressure, EPAP, are set with a desired pressure support and positive end expiratory pressure level, PEEP. This allows more air to move into and out of the lungs without the normal muscular activity needed to do so. It can be used in patients with shortness of breath, COPD, respiratory distress, heart failure, asthma, pulmonary edema, and hypercapnic respiratory failure. If patient is on BiPAP, always keep resuscitation bag available at the bedside. Second is controlled mode. In this, patient receives a set tidal volume at a set rate. 100% ventilation is controlled by ventilator. It is the least used mode because this mode locks out patient's effort to breath. So, it is difficult to wean off patient from ventilator. If the patient attempts to initiate a breath, the ventilator locks out the client's respiratory efforts. Third is assist control, AC or continuous mandatory mode, CMV. It is the most commonly used mode. Tidal volume and ventilator rate are preset on the ventilator. The ventilator takes over the work of breathing for the patient. The ventilator is programmed to respond to the patient's inspiratory effort if the patient does initiate a breath. The ventilator delivers the preset tidal volume when the patient initiates a breath while allowing the patient to control the rate of breathing. If the patient's spontaneous ventilation rate increases, the ventilator continues to deliver a preset tidal volume with each breath, which may cause hyperventilation and respiratory alkalosis. Fourth is synchronized intermittent mandatory ventilation, SIMV. It is similar to assist control ventilation in which the tidal volume and ventilation rate are preset on the ventilator. It allows the client to breathe spontaneously as his or her own rate and tidal volume between the ventilator breaths. It can be used as a primary ventilator mode or as a weaning mode. It is first mode of weaning. When SIMV is used as a weaning mode, the number of SIMV breath is decreased gradually and the patient gradually resumes spontaneous breathing. You may have heard ventilator alarm many times. Using alarm on ventilator will make sure that the pressures and volume stay in safe ranges. There are 2 types of ventilator alarm: high pressure alarm and low pressure alarm. Firstly, let's see causes of high pressure alarm. It can be due to increased secretions in the airway, in case of wheezing or bronchospasm, which cause decreased airway size. Next, if endotracheal tube is displaced or if the ventilator tube is obstructed because of water or a kink in the tubing. Also, if patient coughs, gags or bite the oroendotracheal tube, if the client is anxious or fights the ventilator. On the other side, low pressure alarm can be due to disconnection or leak in the ventilator. Also, if the patient stops spontaneous breathing. In case of alarm, always assist the patient first than ventilator. Now, some special points to remember while dealing with patient on ventilator. Always assess vital signs, lung sounds, respiratory status and breathing pattern. The patient will never breathe at a rate lower than the rate set on the ventilator. Monitor skin color, particularly on the lips and nail beds. Monitor the chest for bilateral expansion. Obtain pulse oximetry reading. Monitor ABG results. Assess the need for suctioning and observe the type, color and amount of secretion. Assess ventilator settings. Assess the level of water in the humidifier and the temperature of the humidification system, because extreme in temperature can damage the mucosa in the airway. Ensure the alarm are set. If a cause for an alarm cannot be determined, ventilate the client manually with a resuscitation bag until the problem is corrected. Empty the ventilator tubing when moisture collects. Change the position of the patient at least every 2 hours. Have resuscitation equipment available at bedside. Next is complication of ventilator. First is cardiac complication. Cardiac output can be decreased as ventilator can increase intrapleural and intrathoracic pressure. Dysrhythmias can occur from hypoxemia and pH abnormalities. Deep vein thrombosis can occur due to prolonged immobilization. Next are pulmonary complications. It includes barotraumas. Barotraumas happens when sudden changes in air or water pressure damage body. Pneumothorax and subcutaneous emphysema can occur when a high pressure gradient between the alveolus and the adjacent vascular sheet causes the over-distended alveolus to rupture. Volutrauma can occur. It is the alveolar damage that results from high pressure resulting from large volume ventilation in patients with acute respiratory distress syndrome. Atelectasis. This is collapse of lung parenchyma from occlusion of air passage with the reabsorption of gas distal to occlusion. Tracheal damage can occur due to overinflation or reduced tracheal blood flow causing ischemia. This can be avoided by monitoring of intracuff pressures and volumes. Oxygen toxicity can occur. Fluid imbalance including fluid retention and dehydration both can occur. Infections can occur like ventilator-associated pneumonia, urinary tract infection. Peptic ulcers can develop due to physiological pressure and stress. Due to sedatives, narcotic, paralytics, neurological complications can occur like agitation, distress, delirium, and somnolence. How will we wean off patient from the ventilator? Weaning means withdrawal of patient from assisted breathing. When the underlying disease process that necessitates mechanical ventilation has significantly improved or fully resolved, weaning procedure should begin. Consider weaning from the ventilator when patient is able to protect own airway, patient is hemodynamically stable, and patient is able to follow simple commands. Unnecessary delay in weaning from the mechanical ventilator increase the likelihood of complications, such as ventilator-induced lung injury, pneumonia, discomfort, increase hospitalization cost. There are 2 parts that need to be done prior to extubation, which are readiness testing and weaning. These should be done on an awake patient. For this we have to do sedation wake-up and daily wake-up. As long as it is not contraindicated, patient should have a sedation vacation or daily wake-up. Turn off sedation and do spontaneous weaning trial screen such as the Rapid Spontaneous Breathing Index. So how it is done? Sedation is titrated down until the patient is able to perform 3 of the following 4 action. Open eyes in response to voice. Use the eyes to follow the investigator on request. Squeeze a hand on request. Stick out the tongue on request. To assess readiness of the patient, most of the hospitals include just 3 or 4 criteria for short-term ventilator patient. ABG within normal limits. Negative inspiratory pressure less than -20 cm of water. Spontaneous tidal volume more than or equal to 5 ml per kg. Vital capacity more than or equal to 10 ml per kg. Respiratory rate less than 30 breaths per minute. Next are the strategies to facilitate weaning. Explain the weaning process to the patient and family members. Position patient to maximize the ventilator efforts, possibly in sitting upright in bed or chair. Administer analgesics to relieve pain and sedatives to control anxiety of the patient. Frequently assess the patient's response. Avoid unnecessary physical exertion, painful procedure, and transport during the weaning trial. Commonly used modes for weaning are CPAP, pressure support ventilation, and SIMV. If patient is not able to tolerate weaning process, following symptoms will appear: increased respiratory rate, heart rate and blood pressure, dyspnea, use of accessory muscles, decreased level of consciousness, diaphoresis, fatigue, pain, anxiety, deterioration in PaO2, PaCO2 and SpO2. Thank you for listening.